Hello, everybody. Welcome to another edition of AFR's EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today I'm joined by two of our senior captains. I have Captain Rob Laprice, our Quality Assurance Captain. Welcome, Rob.
Thanks, Chief.
And Captain Dominic Velasquez from our HTR team.
Thank you, Chief.
Welcome, sir. All right, so a lot to talk about, a very unique case that had a lot of moving parts. We want to focus not only on the EMS perspective, but also the operational and HTR side of this call, because there was a lot of moving parts to it. So initial dispatch was for Engine 9, Rescue 9. We had the full task force along with HTR Task Force, along with Battalion 2, 7, 8, and even one of the consortium docks, an AAS dispatch to a 29 Delta at a residential dwellings where we had vehicles into a home. All right. Rescue 9 and Engine 9 were the first arriving on scene. It sounds like they found a truck that had crashed into the house and it pushed the car that was parked in the garage into the living room where it struck and pinned a patient. I know you were one of the first arriving units as 7-8. Rob, tell us what you saw when you got there, and even before that, what steps did you take as you're en route to kind of prepare for this type of call?
So what I did is I called I could tell by Rescue and Engine 9 size up, we could use a fellow on this scene. So I called Chris Root, and I asked him to get en route, and he got en route. He wasn't on the initial dispatch. And then I was just thinking about how many patients we had. When I first pulled up, Rescue 9 was doing a great job with the first patient who did the hitting. He pushed the car in. He ended up to be just ETOH, but he was altered. We called him a red, and boom, he was off the scene really fast as I was pulling up. Then I went inside. Everyone was kind of getting organized. We had this patient. He was in his mid-70s. He was on the floor. The car was partially pinning him against a pony wall and the back wall of the room. So I already knew HTR would have their work cut out for him. Also, the back tire was kind of leaning up on a ledge. So it was kind of precarious. I knew sheetrock would have to come out and all this. At that point, I was getting ETAs on Squad 2 and see where they were at. Patient was awake. He was talking to me. I was leaning over a pony wall talking to him along with Rescue 9, Lieutenant Renteria. And he was like, "Can you get this car off of me?" and all this stuff. His chest was moving, and I thought it was going to go okay, actually. I thought, he's just trapped. We're going to get him out of here, get him transported. There could be something broken on him, but, you know, he's awake. He's lured. His skin is pink. He's talking trash to us. He was telling me, "Son, go get a jack and get this car off me." And I was like, 10-4, we're working. In the meantime, AS ended up in the house. I asked AS if they could just get some access. He had an arm that was available. They got IV access, and I said, I'm going to go and do a face-to-face. The radio was busy. I want to do a face-to-face with Battalion. Squad was already there at this point, starting to work. Me and Dom had a plan. He had a plan on how to get the car removed. Went and talked to Battalion 2. Came back in, and I looked at the guy, and he was, I could tell he was guppy breathing. We did a sternal rub on him. He was unresponsive. At that point, I knew he was arresting, which actually surprised me, I have to admit. And I told Dom, we need to hustle up. Whatever you need to do to make it go faster, we need to get him out of here.
Yeah, so we had patient pinned initially in that living room. Basically, the vehicle was still on top. Was it the vehicle, or was it just pinned up against another wall?
He was more pinned than the vehicle was on top of him. Like the bumper was, what would you say?
The bumper wasn't necessarily what was holding him down. He was between his chair and the tire.
Right.
The tire was sitting on his chest, partially.
Yeah. So that's where we're at.
So in terms of care of the patient, when you first encountered him, they were able to access an arm. They could start treating at least, what were they using? Just pain meds, or what exactly were they?
I just wanted access.
Just access.
I just felt like this is a guy, we have the time, we should get some access. I think one of the engine companies had an oxygen mask on him, and guys were talking to him. We were trying to take care of him. We just knew we were in a pinch. We needed to get this car off him to get him out. We had a whole team, a whole EMS team right there waiting to snatch him, bags out, ready to go. And then, like I said, I came back in and he was guppy breathing.
So you start to see the deterioration of the patient. You know he's
Absolutely.
going to need some advanced care, but it's absolutely impossible until we have access and then help from the HTR team.
Exactly.
So, Cap, it's pretty regular. You guys get dispatched out to a lot of different events, and historically there's some events that folks can handle on their own with the equipment that's on their truck. Talk to us a little bit about the specialized equipment, the specialized training that your team employs for calls like this where it's absolutely an inaccessible patient.
And I'm glad you pointed it out, because that's something that I mentioned quite a bit whenever we're just having our tabletop discussions with other crews, is that we have very, very capable people throughout our department we have great equipment, we have great training, and when we're en route and we hear the leadership, the incident command asking for an ETA, and the crew's discussions over the radio, and that level of intensity I know is there, then that really lets us know that the show's on. It's going to be a job that we're going to have to do some work. I think that was even said on the radio. This is going to be it's going to take some work. I think is one of the quotes from one of the guys that was on scene. So the size up is critical to letting us know kind of what we're going to need to be doing. But coming back a little bit to what you had said as far as equipment and training, sometimes we just need to lift a little bit higher. We need a tool that's going to be a little bit stronger. It's going to spread a little bit further. Or the patient's just not accessible, and we're going to need the equipment, training, or the disciplines that are necessary to make access to those patients, treat them appropriately, and extricate them.
So as part of the ICS team, it's kind of, we have a lot of moving parts, right? So we have initial command, and they take command of the situation. We have higher ranking officers who arrive, typically battalion chiefs or the 7-8, who can take overall scene command. We have EMS groups that are working on patient care, but there's more to that. So as the HTR captain, when you're en route to that call and you get the vibe that you are going to go to work on this call, what's the ideal role for you, or what position do you typically take under ICS when you arrive there?
The best role for us is going to be part of the rescue group or extrication group, depending on what the incident is going to be. But en route, based on that size up, which is invaluable, we are counting on a good size up from all of our first in teams and trucks, so that way we can start kind of formulating our plan and getting an idea of what path we're going to be going down. Obviously, until we get our eyes on and do our size up, we can't make those definitive decisions. But the size up from the crews that are on scene is critical to us starting to talk in the truck. Guys, sounds like this is going to be an airbag job. This is what I need you to do when we get on scene. And in this instance, I told them, I'm going to get in there as quick as I can, get eyes on, size up, stay at the truck, open the compartments, and be ready to pull off whatever I call for and get there quick. Because it was evident that time is of the essence, and we were going to have to work fast.
So it's safe to say that early command, right? Taking command early, assigning those roles, knowing you have HTR coming, assigning them as your rescue group supervisor, your extrication group, whatever you title that as command. It's their decision after you assess that scene, after you assess that situation, is really going to dictate the care that you're able to provide, and has to change your game plan. So face-to-face operations, or at least communication between the EMS branch and the HTR team, is probably vital. How did that work on this scene?
I thought it worked perfect. We were both objective, humble, and we knew the tactical objectives that we each had to get done. And we communicated those to each other to provide the best patient care, I would say. I thought it went really well. I don't know, would you like to add anything?
Having feedback from somebody who's primarily focusing on the patient is critical to us determining our mode of operation and the speed that we're going to be operating. because our team is very task oriented in that extrication and stabilization and getting the actual physical job done. Trying not to take into consideration the patient, but not really keeping eyes on all the changes that the patient's going through.
Yeah.
So by getting updates from Rob allowed us to adjust the speed that we were working and make adjustments to our plan. Because I mean, even though this is just it became an HTR event, we still have a person, we still have a patient there that we can't lose sight of, and that's the whole reason why we're doing it. So having somebody reminding me of really what it is that we need to, where our focus needs to be, was vital.
And you were reminding me of the safety steps that couldn't be skipped, that you needed some time here and there, and we're making accommodations for that. So I appreciate that.
And
too.
the trust that we had in
Yep.
each other, that you're doing everything you can, and you trust that we're doing everything that we can to make sure that this is going to be a one-time, one-shot lift, no mistakes made, and nobody's going to get hurt.
Yep.
It's a unique makeup on the HTR truck, I would imagine, whereas typically there's assigned roles on an engine per se, with an officer, a driver, and 2 firefighters. With the specialized training that everybody on your truck has, what is the team dynamic when it comes to interacting with a call like this? So as an example, is it a matter of teamwork, working together? Because everybody has varied experience in different areas of HTR, I would assume. And you guys work together cohesively to kind of make these decisions. Is that fair to say?
Yes. The training and becoming cohesive as a group really is training. It comes down to that. I mean, we know that as firefighters, that the more we train together, the more we get our hands on the equipment, the more proficient we're going to be. Taking the class one time several years ago and then jumping on the truck isn't going to cut it. You know, we need to be working together on a regular basis so that way we can maintain that level of proficiency as a team, not just as individuals. We got to pull the stuff off the truck and get our hands on it, whether it's a pumper, rescue, or a HTR truck. That's very important to maintain our skills.
Getting back to the patient now, setting the stage for the scene, we provided oxygen initially. That's really all we can do. We were able to access an arm so we can get IV access in case we needed it. But we started to see that the patient started to decline. Tell me about the interactions between the two. When you identified that this patient was declining and now we had to get them out immediately, how did the operational game plan change between you and the HTR team that was helping you remove the patient?
Once I saw that, I went straight to Dom and I said, he's crashing. We need to get him out now, whatever you can do. And he listened to me and he did a hastier lift, right? Still a safe, but a hastier lift.
Yeah, in a sense. What the goal on scene, because like you said, the way that the vehicle was positioned, the front of the vehicle was somewhat being suspended by the patient and the furniture. We had to remove a wall to get access to the front of the vehicle, which I believe Engine 9 crew helped with quite a bit. We had to clear out that room to actually have room to work, because initially the patient wouldn't even fit in there with us. And in that wall, there was water lines, electrical lines. We needed to secure utilities. We're on the radio trying to get that stuff happening. Of course, the time for that to actually happen seems like forever when you need it done now. So we were kind of dealing with the sparks and stuff like that for a minute while we were gaining access. But the goal ultimately was, because the vehicle wasn't sitting on its tires, it was kind of suspended, was to do a multi-point lift from both sides of the vehicle while stabilizing it and capturing all that progress. We were working towards that. You know, the tool that made that possible was going to be our high lift bags, which is the medium pressure Paratech bags. That particular set that we have will give us somewhere in the neighborhood of about 24 to 36 inches of lift. And high pressure airbags on the passenger side. But we had to build cribbing to actually get up to where the vehicle was. We already know there's space between the ground and most vehicles, and then now this one was suspended off the ground. So we had a lot of cribbing that we had to bring in from the truck. And what made it difficult was we had to go from the street all the way to the backyard in through the back of the house.
Good point. Yeah,
that was
true.
very challenging to get all the equipment.
Everything was
quickly.
collapsed in.
Yeah.
So we had to go around the back way to get in.
So Initially, that was the intent, was just to do a tandem lift and bring the vehicle straight up. But when things changed, because the patient started to decline, we turned that right side, the passenger side, into now just the capture, and decided to just do more of like a cantilever lift and just lift up the one side that the patient was on. But we positioned some high pressure bags on the front of the vehicle to maintain the balance and capture any type of shifting of the load that tends to happen anytime we're going to push on one side. So we can't just lift on one side and let the vehicle go wherever it goes. We have to maintain control of our loads and capture it every inch of the way, because it could fall on our patient in another place, and then now we just look unprofessional, or it could fall on somebody else and hurt them. So all that is things that had to be taken into consideration, and the change was just to do that cantilever lift rather than a straight full vehicle lift.
So when that patient started to decompensate, it kind of changed the trajectory and the plan for removal of the patient, but we were still able to do it safely and effectively, and we got enough lift to be able to remove that patient from that site. And we talked about how the scene was pretty dynamic. You talked about the complexity of having the electricity still active, potentially gas, water, a lot of things going on. Do we have to wait for that to be secured prior to us implementing that final lift?
There was no. It happened while we were getting other work done. There was ways that we were able to cut the wall and avoid those hazards, but still make some forward progress in our efforts. And then at the last minute, when we got report from IC that those utilities were secure, then we were able to make that cut and give us full access. But there was still a lot of progress that we were able to make around those hazards.
But we absolutely were able to save time by making that adjustment based on the patient condition.
Yes.
That's awesome. So we've been able to remove the patient safely. The vehicle is cribbed, everything is stable there. What was the next steps in terms of patient care?
So I was working with Rescue. I had Rescue 4 and Rescue 13, and I need to give them all props. They were excellent on this call. I kind of hijacked Rescue 4 from Dom, but he let it happen. I was using that crew also. We had our bags out, and the plan was, hey, everyone grab a leg. That's all we could grab. And once this car goes up, we are going to snatch him. And that's what happened. Dom called it. They lifted. We snatched the patient, and now we had him. And he was right there on the floor with us. There was two schools of thought. I had one school, someone wanted to take off with him, load and go. I had another school, someone wanted to treat him as a trauma arrest. Double dart, call it. I saw him as probably 70% asphyxia, 30% trauma arrest. I felt like we had to rule out the trauma arrest part, but we should start working on him. I felt like he was hypoxic, and that's what he needed. So that's what we did. I got my way this time. We were able to get on the chest, start compression, start with a BVM. We double darted him. I'm really happy we had the line. That was a good call because we just pushed epi right away. We went ahead and pushed bicarb for crush, and we got into a PEA, and a few minutes after that, we had a ROSC. We had pulses back on him. The doc showed up. Doc wanted to ensure his chest was good. He did bilateral finger thoracotomies to make sure there wasn't any blood or air that needed to be removed. And we loaded him up, and we went to UNM.
Incredible case. I could see that being a point of discussion on this was a unique situation, right? This is like a traumatic event. Do we treat this as trauma arrest? But I think you all made the right decision in that really the cause was the pressure, right, on the chest, that potentially he couldn't get good breaths in, and that led to the arrest. So I think you guys handled the appropriate way, and obviously so because you got the quick ROSC and were able to initiate transport.
I thought he was like cumulatively hypoxic. I missed it. You know, I saw his chest moving like I told you, but, you know, it must have been too much for him. And he had some comorbidities. He was mid-70s. He had some other stuff. So he's kind of frail in a way. He's not like a young guy's under there. So, yeah.
Were you able to maintain that ROSC in transport to the hospital?
We did, all the way.
That's awesome. Talk to us a little bit about crush syndrome and what we should look for, because this situation is unique. Obviously, this is an extreme example, but there are circumstances where it would involve HTR. A lot of times we've had calls in the foothills where somebody's wedged or stuck in a position that's precarious. But what should we look for as providers in terms of crush syndrome and how to treat that?
So crush syndrome is a lot of times like a sustained crush, for a while, where you can have muscle breakdown, acid buildup, lactic acid buildup, and a lot of times when you release that pressure, when you release that crush, they can have like a flush, and that's kind of like a toxic flush. That's why we're always trained to get your IV access if you can, have bicarb ready. That's one of the fundamental drugs you can push for it. We pushed 1 milliequivalent per kilo, and that's pretty much it. Don't think they're going to be the same as when everything was on them. When it comes off, that's when it can get interesting, or you can get in trouble that way. That's why it's an issue.
And as far as treatment or preparing for that situation, before the HTR team comes in, they're able to alleviate them or remove them from whatever that area is. What are some things we can do to be ready for that, to kind of get ahead of the curve?
I like to have bags out, ready to work, and not ready to run. We need to have bags out. We need to stabilize that patient. Ideally, it's nice to have access. Nice to have an airway out. Just be ready for the worst. Don't be surprised. Like, I wouldn't pull someone out from a crush situation and then have them crump and be like, oh, I'm so surprised. It should be almost predictable, where it's not surprising if it happens that way.
We talked a lot about the HTR unit, specifically Squad 2, but there is a whole task force associated with this, and there's reasoning behind that. So can you talk to us a little bit about the makeup of what the HTR Task Force looks like and why it's important to have each one of those pieces when they're responding to these calls?
Right, so it's based on our minimum staffing. The squad is going to be the only vehicle that's required to have all 4 techs. We're required to have 2 operations level on the engine, and at least 1 operations level on the squad. On the rescue. Okay, and we didn't always have any training requirements on the rescue. That's something that's been worked on throughout the program's existence, and Spain and our previous program coordinator, Chris Carlson, worked on that very hard to get those positions allocated for somebody who was trained. And it goes kind of hand in hand with crush syndrome and suspension trauma, which is also very similar to that same type of injury pathophysiology when it comes to our patients. We need somebody who at that paramedic level, or at least intermediate, somebody who is capable of administering the types of drugs needed to treat the patient appropriately, if somebody who is not trained to make access to a confined space or involved in the search and rescue in a collapse. That's why it's so important to have those people that have those higher level of medical capabilities on the team, so that way they can treat our patients in those complicated situations. So we all train together. Every position is just as important, and sometimes maybe even that paramedic that is on the rescue may be the first one to go in and make contact with the patient. That may be the most appropriate way to treat our patients, and then the rest of the guys can come in and help with the extrication.
I was fortunate enough to be able to be part of the hot wash of the after action review to this event the evening after it happened. You guys did a great job of pulling the crew together and talking about successes and potential areas of opportunity. If you had takeaways from this specific event from an HTR perspective, is there anything that you would do differently, do again, or what takeaways would you share with your team moving forward if they were to encounter this type of call?
So the things that we talked about was making sure, obviously, that our team is as available as possible. Staffing, we sometimes have to work on that together. It's difficult to maintain staffing on all trucks, and the task force is no different. So it's important to have as many trained people as we can. We were lucky enough that day, I think 3 or 4 of our normal crew were gone, but they were replaced by other people with overtimes and support fills of people who were trained. And it turned out to be very beneficial. I would have had to become a lot more task-oriented rather than being able to maintain that global perspective and communicate with Rob from the head of the vehicle if we didn't have each one of those people in place. So the biggest takeaway for me was the command structure of just the operations portion. I was, I think, very critical of myself because, and sometimes I ask myself, maybe I'm not being real fair with myself. You know, was this that incident where we didn't have really the time to say, okay, your passenger side, your driver's side, your front of the vehicle, you're going to be my equipment runner, all the things that we set up in training that is supposed to make everything run perfect. That was now just all in my head, and I was very much a dictator on scene, saying, do this, do that, get this, run and get that, go here. And, you know, maybe that might be appropriate for the time that we had and that type of incident. But I feel, honestly, being self-critical, that I am going to try to do better in that with that in later events next time. I asked my crew to be critical of me, and they don't tell me anything. So I figured this is what I'm going to do. This is how I'm going to complain to myself about myself. So, you know, this is a very forgiving job, and it's very difficult. And sometimes we just need to step into that role and take command and make things happen. But having that hot wash or that tailboard afterwards is critical, so that way we can be honest with each other about things that we could do better, or things that we would have liked to have done different.
Yeah, absolutely. And I think the situation dictates, right, your style on that scene. So although we want to be collaborative and involve everybody in like what the appropriate steps would be, sometimes if stuff starts going bad, like we got to act and kind of take on that role of being more decisive and just telling folks what they have to do and what their roles are. Mm-hmm. Last couple of minutes here, but from an EMS perspective, I think we've talked about this at length, and I think the care plan was perfect for this patient, not to treat it as trauma, treat it more as a medical. Any takeaways from this that you would do differently the next time?
Probably just training. I would like to just emphasize, like you saw in the hot wash, that traumatic asphyxia, crush, they might seem stable, but to please remember they're predictably unstable, and anything can happen, and we need to be ready for the worst. Mostly if we have time to set up while HTR is doing work, we shouldn't be wasting that time. And that's really my main takeaways. And it's not always, one more thing, it's not always black or white. It's not always a trauma arrest or it's straight medical. Sometimes you need to make that judgment where it's both, and you have to rule out certain things to do the best patient care.
And a call like this adds to our experience level now too, so, right? So now when Cap arrives with his team to a call, they're already thinking through that. So preparing the initial arriving crews, like, hey, we're going to get set up. Are you guys preparing for crush? Are you preparing for a potential asphyxia? Like, I think it just makes us better when we encounter situations like this that are learners.
And again, these rescues that I was with were excellent.
Perfect.
Yeah.
We could talk about this forever,
I know,
but I'll give you the last word, Cap, because
Yep.
I'll put you on the spot for just a second. In terms of, we have a lot of new officers that are on rescues, engines, even ladders. From the HTR perspective, as HTR captain, what's the message you would like to share with the rest of the field in terms of what your capabilities are, what your expectations are of training, how often do you want to train with other crews, but what do you want them to know about your program?
About our program is that we're there to help. We're there to come and assist you guys in taking care of that patient and taking it when the equipment and the training that we normally get throughout our normal day-to-day operations isn't just going to get the job done. But what you do on scene prior to us getting there is going to make the overall outcome that much better. And that's exactly what this crew did. Nines, they already kind of foresaw what was going to happen, and we've trained with that crew. Some of those guys that were on that crew have been on the HTR program. So this training doesn't just go away as you move throughout your career. Take it with you, and there were some individuals on that team that knew had an idea where we would be going. So they started with debris removal and giving us access. When I rolled in, I saw that there was guys with already tearing the wall apart, already moving equipment out from underneath the vehicle because they had to give us access underneath. There's things that can be done. And like I said, everybody in our department is very, very capable. We're just bringing that higher level of equipment and training and proficiency with that equipment that's going to get it to that last final step that our initial training and equipment isn't going to get us. What's going to help us get that job done even more so is a stabilized incident, command established, even if it's a multi-vehicle accident on the highway. It's very important that we have somebody in charge that I can go to and say, what do you need? I'm not going to roll up and try to take the show. I want to be assigned to rescue group, extrication group, not incident command. The last thing I want to do on scene is have to stabilize the incident. So if our team, our crews that are on scene first, get that done, and it's organized, and we're going to just roll into our assignment where it's most needed and go to that job, then that's the best use of our resources.
Outstanding. I appreciate both your time. It's a longer podcast than we normally do, but I thought it was appropriate to have. There were so many nuances to this call that I thought were great education pieces, so I appreciate you both taking the time.